Good morning, everyone. Today I'll be speaking about a novel technique of creating temporal capsulorrhexis to counter negative disc photopsia in cataract surgery. Disc photopsia are unwanted visual phenomena which occurs after a routine cataract surgery, which can be a positive disc photopsia in which patient complains of glaze and halo, and negative disc photopsia in which patient complains of a typical arc-like shadow in the temporal field. The leading hypothesis for cause of negative disc photopsia is the light which is incident from the temporal side on the nasal periphery of IOL creates a illumination gap which leads to this negative disc photopsia. Our hypothesis is that if we instead of creating a central capsulorrhexis, if we create a slight temporal capsulorrhexis, we can eliminate this illumination gap and thus negative disc photopsia. For this study, total 150 eyes were taken, 75 in the study group and 75 in the control group. We have kept the gender, age, type of cataract, anterior chamber depth, pupil size, type of IOL and surgeon all same to eliminate any confounding factor. And for each patient, one eye was operated with a traditional central capsulorrhexis, and that eye was kept in the study group, and the other eye was control group, and the other eye was operated with slightly temporal eccentric capsulorrhexis, and that eye was kept in the study group. Follow-up for these patients were done on day 1, day 7, after 4 weeks, after 3 months, and after 6 months. And the incidence of negative disc photopsia was noted based on history. So what exactly do we mean by creating a temporal capsulorrhexis is shown in these photographs. These photographs were taken in the OT table. The surgeon is sitting on the temporal side. And we can see that instead of creating a central capsulorrhexis, we have created a slightly eccentric temporal capsulorrhexis. This is the photograph after the IOL implantation, in which we can see that the overall size of the rhexis has not been exceeded by 6 millimeter. So instead of being slightly eccentric, we have taken care that there is a 360-degree overlap of the anterior capsular rim over the IOL surface. Only the idea is that the nasal temporal rim should be broader than the temporal capsular rim. And this is the post-operative results that we have got, in which we can see that there is a clear decrease in the incidence of negative disc photopsia in our study group, especially after 1 month of the surgery. So the incidence of negative disc photopsia according to a long-term study is 15.2% on day 1, which decreases to 3.2% after 1 year of surgery. The reason for this decrease in the incidence is because of first is neuroadaptation, and second is because of the opacification of the anterior capsular rim, which eliminates the illumination gap. So our hypothesis is that if we will create a broader nasal capsular rim, it will opacify earlier and it will block a larger chunk of peripheral rays and thus eliminate the illumination gap and thus negative disc photopsia. The advantages of this study is that it is very easy to learn, and there is no increase in the surgical duration or expenditure. However, there are few limitations that a long-term stability of lenses has to be studied. Then a larger study group which involves the experience of other surgeons has to be studied, and the diagnosis of disc photopsia is based on history, so it makes it little subjective. But despite this, it's a very easy modification of the traditional method to counter a very frustrating complication. These are my references. Thank you.
What is the exact dimension by which you actually shifted for temporal capsulorrhexis?
Ma'am, around 1 millimeter, ma'am.
1 millimeter.
1 millimeter. Yes, ma'am. We were not able to exactly control it that every shift is by 1 millimeter only. So we have defined a group, like the size of the rhexis should be between 5 to 6 millimeter, and the shift should be between like 0.5 to 1 millimeter, not more than that, ma'am. Any rhexis which is larger than this or the shift is more than this, then we have eliminated that eye from our study, ma'am. That exact shift and the exact rhexis we were not able to control for each and every patient, ma'am.
But then in inclusion criteria, while you were evaluating the cases, suppose if you found that if it's not exactly matching your criteria, so did you exclude those cases?
Yes, ma'am. We have excluded those cases, ma'am.
Okay. Okay.
What is the follow-up period for this?
Pardon me, sir?
Follow-up period.
Follow-up period, abhi we have followed these patients only for 6 months, sir. This study is still going on, and beyond 6 months, we are in touch with these patients, and we will be following this patient for another 2 years, sir, so that we can comment something on the long-term stability of the IOL, sir.
So an eccentric, little bit eccentricity to the capsular axis may lead to a disorganized capsular contraction force.
Yes, sir.
and that will be evident after, much after 6 months, maybe in 2 years. So that capsular contraction force may have a negative effect on this eccentrically enlarged
Sir,
capsulorrhexis.
sir, we are keeping a tab of this. We are also recording astigmatism of each patient in each visit. So
Please
we can
follow
study
up
this.
for next 2 years
Right, sir.
and then publish another paper.
Right, sir.
Thank you.